Hello everyone, my name is Samuel Dab. I'm a student here at SIPA. I'm also a research assistant with Professor Healy, with whom I've been working on cybersecurity regulation harmonization, and more specifically why we currently are in a state of regulatory disharmony. And it's my great pleasure today to introduce our panel on cybersecurity in healthcare, and I will hand it over to our great SIPA adjunct professor, Beth, who is going to introduce the panel.
Hi, everybody. I'm Beth Cartier. I'm an adjunct professor here at SIPA. First, I want to say thank you so much to SIPA and Columbia for putting this on. And I'd love to have our panelists introduce themselves, and thank you so much for joining us today. Ari, do you want to start?
Sure. I'm Ari Schwartz with Venable and the Center for Cybersecurity Policy and Law.
Hi. Hello. Drew Hanchett. Hi, how are you? I'm the Chief Health Information Officer at the Department of Health in New York State.
Hi, I'm Beau Woods. I wear a lot of different hats in healthcare, but most notably, I'm with an all-volunteer pro bono initiative called I Am the Cavalry, and I help run an event called the Cyber Summit in DC and often in California.
Thanks. I'm actually really excited about this panel. I know people aren't like, yeah, cybersecurity regulations in healthcare, this is wild. But I really do think that we have a really great sort of breadth of opinion here. So why don't we sort of start with just sort of looking at the current state of regulations and frameworks, right? We look at two huge breaches this year, Change Healthcare and Kaiser. You know, they're at least sort of compliant with some of the common frameworks. So what does that tell us about sort of the current state of regulations, the need for regulations, and sort of the current environment? Ari, you want to start?
Sure, although I think maybe Drew should start. He's actually coming up with the regulations. I don't know. But,
yeah, so it's interesting. I fancy myself a cybersecurity practitioner, not a cybersecurity expert, so I'm very excited to be sitting here with experts, but you know what it says is current state isn't working, right? When we address these attacks that are going on now, so in New York, we took the step to promulgate some regulations. It was a long process. I think we did it. Hearing conversations yesterday at the federal level, they were talking about rolling out regulations and then hearing feedback on them later. We took the preemptive steps of having those conversations with our healthcare providers and our healthcare associations early. We've had a couple rounds of regulations, a couple rounds of public comment that we addressed in feedback. So it really was a collaborative effort to get those big baseline regulations out the door. Are they perfect? Probably not. I don't think there is a perfect regulation that comes out, but New York State felt like there was a need to do something and push the envelope there. So we're excited. The regulations are out. Our healthcare providers in New York, our hospitals have a year to comply with those, and we'll be working in lockstep to make sure that that kind of rising tide raises all boats type of thing.
Yeah.
I was going to say, I think that you're seeing that kind of response from regulators broadly, where you have that in several other states as well, where there's some interest, at least, in regulating, and then you also see the HIPAA security rule, new HIPAA security rule draft is expected out before the end of the year, and you have two different bills in Congress, neither of which are that likely to pass, but still, a lot more momentum toward regulation in this space than you've seen in many years in healthcare, because of the incidents and also just because there's been a general feeling of failure in different parts of the sector.
Sure, but even your initial answer is that you're sort of getting immediately to some issues you might have, like complexity, right? We're talking about hospitals, federal, nonprofit. So what are some of the challenges? I know we're not going to get perfect, but sort of what are the challenges specific to healthcare and regulation that we're looking at?
Yeah, I think healthcare is really interesting. It's different for a lot of reasons. One, it's the nature of modern healthcare is hyper-connected. So in doing some of our tabletop exercises, clinical simulations, talking with a lot of hospitals through the Cyber Summit, we learned that if hospitals don't have fresh water for like 2 or 3 hours, then they pretty much shut down. You're back to, pre pre-modern industrial healthcare. And it's really, really hard to do anything because the doctors have to wash up and all of that. So interconnectivity of like healthcare with water, healthcare with power, obviously, with cold chain and logistics and transportation. So if you don't get medications there in a certain time under a certain temperature, then they go bad. That's one of the complexities of healthcare and one of the things that makes it unique. Secondly, I would say that within healthcare, there are many different sub-industries, like medical device manufacturers, who have very different sets of incentives, very different capabilities and roles to play than healthcare providers, which are different from electronic health records manufacturers, which are different from payments and billing, which is different from insurance, which is different from, you've got all of these others that make it difficult. And then third, and these are not the only differences that make healthcare different, but the consequences in healthcare are different than the consequences in financial services, for instance. So I know that, Ari, you mentioned HIPAA, and a lot of people, when they hear healthcare cybersecurity, they think, oh, well, patient data, that's the thing. But I want you to stop thinking about patient data and just, at least for the session of this panel discussion, whenever you hear security, think patient safety, think patient lives. When I was at CISA, I spent a couple of years at CISA along with Jay and some other folks, and we did a definitive analysis on a healthcare ransomware that showed when a hospital gets hit with ransomware, there's an uptick in elective mortality rates. In other words, people die from ransomware. It's not about patient data, patient health. Care that's denied, degraded, or unable to be delivered. Those are the things that I care most about in healthcare, but it makes it tricky to do when you have a lot of requirements that are focused around data, for instance. So, the idea that we generally have in cybersecurity of like, if you get your password wrong 3 times, lock people out. When I was working at a hospital, you walk in on a Saturday night and you see that the doctors are going around, they always forget their passwords. So if you lock them out after 3 times, then they've got to call the help desk to get it reset. That's a 15-minute process. How many people are going to die in that 15 minutes? Well, on a Saturday night, a busy Saturday night, it might be non-zero, and that's probably not okay. That's a policy failure to have people die because of your security controls and protections. It's also a policy failure to have people die because you don't have security protections in place. So it's a very different type of scenario and environment than a lot of other industries.
Go ahead, Drew.
No, just a quick follow-up on that, because the intent of the regulations in New York are pointed just towards that, right? To that continuity of healthcare for patients. We have a very mature health emergency preparedness program in New York to respond to other threats, as you mentioned, storms, water, and it all comes down to are our entities ready and able to deliver that healthcare. And cybersecurity is just another aspect, another threat of that, where we didn't have those in the book of regulations that we have for our entities. And how do we start to, as a state, identify that, reduce the scope of that threat, and be helpful in terms of response?
I think it's really interesting because I think from the business aspect of things, you always hear about sort of, the lockout issue, but to really tie that into sort of the patient impact, it's not just a business continuity thing, it's really a patient health thing. But you did touch on ransomware, which I know is huge in hospitals right now. It's a very, topic of a lot of concern. Where is the responsibility, if any, for the government to sort of help hospitals prepare and respond to that? Is that a shared responsibility? Sort of where does that sort of shared model lie?
Yeah, I mean, there is some concern, some piece of this that is government-oriented. One thing that has been raised, and I think there's been some focus from the federal government, and some states have gotten involved now too, is the focus, going back to some of the things Beau was talking about, the things you need for hospitals to be able to run. Rural hospitals have a particular problem, right? Because Here, a hospital might be able to get shut down for ransomware, but you can go to the other side of the park and go to another hospital. Yeah, people might die on the way there. In some cases, it's not the greatest situation, but it's not that far to go. But in a rural space, the closest hospital might be 100 miles away. And so there you end up with a situation where people are going to die, absolutely, if the hospital gets shut down. So that is a lot of the focus right now, and I know some other countries have looked at what the U.S. is doing there as a model as well, which might actually help in some ways with the international harmonization of it as well. I don't know. Drew, you were talking a little bit before about the role, things you're looking at in rural spaces too. So.
Yeah, it's really interesting. So as we went through our public comment period, so first of all, I'll say across the board, there was nobody that was opposed to them in general. Everybody was like, regulations, paying attention to this is a good idea. They had major concerns on particular areas, and one of those that came up is how do we support those more rural or segregated hospitals, right? So in New York, as you well know, we have very mature hospital systems and larger hospitals. And it was interesting in our conversations with them. So we had some of our larger mature ones raising that concern. Well, what about, the small ones, neighborly? So, that brings us into discussions around how do we support those smaller, more rural entities. And people were raising their hands to help think through that and support from a shared service model. Or one of the parts of our regulation is that hospitals are required to have a CISO on board. What does that look like? Do they have the resources to actually do that? So we start to look at things like potential shared CISO model. So 3 rural hospitals have a contracted CISO that really can support 3 different entities, as an example. So it definitely come up as a concern, and I think in New York we have hospital associations and large hospital systems that are willing to work with us at the state on these regulations to really figure out ways to support them as well.
I think healthcare is really interesting in the shared model of responsibility because there's regulations not only on the healthcare providers themselves, largely at the state level, a little bit at the federal level through Center for Medicare and Medicaid Studies, but there's also regulation on medical device manufacturers. So some of the equipment going into hospitals. And I think that the National Cybersecurity Strategy calls out very clearly that they want to see more of that across other industries. More of that type of shared accountability of pushing accountability responsibility upstream to some of the providers who are in the best position to fix some of these issues at their root. And as an example, when I was at CISA, spent a couple of years there, like I mentioned, we saw that at one point a bunch of hospitals got hit with ransomware all at the same time. And we traced down the root cause, and it was their EHR vendor who had opened up a remote administration terminal on their networks, didn't tell the hospitals about, and the hospitals couldn't change from that provider to someone else in the middle of COVID. So they really had no choice. And yet electronic health records providers are excluded from regulation from some of the FDA's medical device regulations, even though they might fit that. There's been a deliberate choice to not have them as a regulated entity. So I think that one of the things that could be in the shared model is that the government can ensure that regulations are applied in a smart way. So it's not just putting 100% of the responsibility on the healthcare providers themselves. It's ensuring that it goes upstream to some of the other providers in that space. And in particular, I think the Change Healthcare for all of us showed us how dependent healthcare is and patient health is on insurers and insurance and keeping the payments flowing. So while there was some requirements and regulations around payers before, I think that strengthening those to the resilience of care delivery, Drew, like you said, from kind of an all hazards approach could be a way that we could balance the load across the healthcare ecosystem.
So I think there's a lot there to dig into, but I think the obvious question, since it's sort of this regulation panel, is when we start talking about medical device manufacturing and sharing the burden and pushing things sort of upstream, how does that impact innovation, right? We start talking about, wearables and AI and, where is the sort of the sweet spot between regulations that are practical and effective and not stifling some of the more impactful stuff on, patient safety and health that might be coming down the line?
I think that regulation, particularly in this area, can be fantastic for innovation. I don't see that those two things are at odds, even though often you say, regulation, innovation, stifles. It's like, it just stops the conversation, but I think it shouldn't, because regulation and changing directions can focus these organizations on what you want them to focus on. So in last October, some of the FDA's new guidance on medical device manufacturers went into effect, requiring them to submit security plans, security programs, evidence of security capabilities alongside their submission to go onto the market. And many of the most innovative medical device makers who have popped up in the last decade or so, they're entirely used to building some of these security capabilities into their development process. When I was at the FDA, we worked with a handful of organizations, a handful of medical device makers on new pathways to market for software as a medical device. And it was funny to see that some of the things that, half the room was old legacy traditional medical device makers. They said, you can't do any of those security things. That would stifle innovation. It's just not possible to do that in software. The other half was these young startups. They said, wait, you can't build software without doing those things. Like, what are you doing? This is archaic, right? So I don't think that those two things are at odds at all. And in fact, I think that if we want to see better outcomes, we want innovation toward those outcomes rather than just indiscriminate and everywhere.
Yeah, it's the innovation versus stifling it and regulations and control. I approach it from a parent perspective, right? So kids want to go outside and explore and play, right? There's 3 different paths. We lock the door and say, you're not going. Then we're all miserable, mom and dad included, right? Or we say, go on out and go play, no holds barred. Then mom and dad are still a little nervous, and or miserable. Or we set them loose with some guidelines, and that could look like we're going with them, right? And then we go out and we explore it together, and we're teaching and we're learning together and setting some guardrails around what it looks like to explore, right? So it's really those 3 approaches when it comes to this as well, and which one are we going to take? And from state government perspective, we're kind of one of the parents in the room right now. So those are the decisions that we need to make.
I mean, I agree with what's been said, although I would put it in the context of some of the things that were said yesterday about the balance between risk-oriented regulation versus controls-oriented regulations. That's not saying that you can't have some types of control, but if you say, well, we need to have multi-factor authentication on every piece of technology, and then you require a certain type of multi-factor authentication, that's not going to work in the hospital context that Beau was talking about before, where people have to have access immediately to some things. It has to be a certain type of multi-factor that works for that kind of device, and certainly those that are more like app data centric versus something that's more akin to operational technology, you're going to have different types of multi-factor or different types of even authentication that's necessary for that to be able to work. And if you try and just come up with the one that you think that for the especially in a sector as diverse as this, try and come up with the case study that you saw that failed at one point and try and put that on the whole industry without thinking through all of the permutations and all the secondary consequences, it's going to end up in a situation where it will stifle innovation and actually people just won't follow it. So I think that it has to have that kind of more risk-oriented structure to it, with a little bit more detail on top of that to make it work.
I think it's really one of the more complex parts of this, right? You have, again, my healthcare background is more like software application related, very, very different than a legacy hospital environment, right? And balancing those two, I think it's a frustration that we've had because like our needs are so different, both from a actual need of security and also the inability to comply with some of the current sort of frameworks out there. That does, however, I can't wait. I think you have teenagers, so I really would love to see how this parenting model works.
That's as far as I'll take it. Sorry.
They're not here. But as far as, we've also touched a lot on sort of cross-sector coordination, right? Understanding that, there's like nonprofits involved, there's obviously industry involved, insurers. Where are some sort of areas where cross-sector coordination is currently working, and where are some areas of opportunity?
Well, I mean, I'll point to one that we work with very closely, which is of the ISACs that are out there, the information sharing and analysis centers for different sectors, the Health ISAC one, especially over the last 10, 15 years, has become really one of the big success stories where most of the industry is really working together now through the ISAC, getting threat information out there, looking at the analysis, working with some other sectors, doing exercises on a regular basis together, learning from each other. If you're in the healthcare sector and you're not working with Health ISAC, highly recommend getting involved there. And I think that has been a success. It crosses all these kind of boundaries that we're talking about here. And it's been able to kind of address some of the questions about like what happens in different subsectors here and how do we get them to engage together.
Yeah, so from my perspective, I would just echo Ari. We've been engaged with Health ISAC. We find it a great resource from a state perspective in terms of that threat intelligence. And over the past couple of days, yesterday in particular, they were talking about harmonization across sectors. And I think the healthcare sector is so complex that I'd love to focus on harmonization within the healthcare sector first, and then maybe we have some good lessons learned there when we start to look across sectors. And the Health ISAC is one model I think that is effective in the healthcare sector.
I mean, on that point, I'll just pick up on your point about the complexity and how regulations work together and being able to read that across sectors and do harmonization. I mean, this is exactly what the NIST cybersecurity framework was built for, as people know. I mean, I worked on it from the beginning, so I'm a very big advocate for it, and it's been very successful, and most sectors have picked up. But the health sector is the perfect example for that because you're talking about the complexity there, and then you have the ability to boil it down to the same sets of controls and the same even up to the function level, say function control, sub-control level here, and that allows it to work across sectors, right? So the things from other sectors you can bring into the healthcare sector, but even across the subsectors within healthcare, we know that what the control is, that allows it to be a lot more risk-oriented, and you to write the regs and write the rules internally and write profiles around that within an organization that can work across the different subsectors here based on that control set.
So I'll disagree a little bit with that. I think it was 2022, CISA put out their cyber performance goals. It was, I think, 35 or 40 different specific things, many of them light touch, like put a security.txt file on your website that has your security contact info so people can contact you if you have an issue. And the White House said, we want these to be the baseline for all industries. We think they're common across all sectors. So take these and build on them, extend them for what works in your sector. The healthcare sector, hospitals, healthcare delivery organizations came back and said, yeah, we're going to cut that number down by half. And then of that half, we're only going to say that 10 are really important and the other 10 are optional. And Nate Kuchar, who's the CISO of Vermont, University of Vermont Healthcare, when they got hit with ransomware and they were down for several months, he said that they had almost all of those. They had all of the 10 required, 8 of the 10 optional ones, and they were still down for several months because it wasn't about IT operational capabilities. It was about restoring healthcare delivery and that continuity of healthcare delivery, like Drew talked about. When the healthcare specific cyber performance goals were released, they said, all right, this is what's going to get us out of critical condition by 2029. And that was, I think, a week or two after Change Healthcare happened. So I don't think it's acceptable to most people to have more and more Change Healthcare style massive disruptions for another 5 years. I think we need to do something more, and we need to do something faster than what those can accomplish. And maybe it's not, the 40 of the CISA cyber performance goals. Maybe it's a subset of that. Maybe it's a handful that can stop the majority of these types of issues. Or maybe it's looking at things like, doing more, you do emergency disaster preparedness around tornadoes, earthquakes, hurricanes. What about around cybersecurity? Can those be part of what gets instantiated into some of the hospital resilience and healthcare delivery resilience that we all want to see?
I mean, your summary there is exactly the problem I've had with the cyber performance goals, right? What you spelled out, which is it is trying to boil it down to something less than the NIST cybersecurity framework, right? And so the NIST cybersecurity framework is looking at this, and then you can have profiles that do, for the healthcare sector or for a subset of the healthcare sector, and then you can have a profile that's ransomware oriented to cross-cut that, and you can focus on those main controls in order to get to say, okay, this is how we go about protecting it. But if you say, we're not going to do all the cybersecurity framework because that's too large for a small organization to understand, or we want to focus on measurement. They've used lots of different reasons that they want to boil down the number of things from the cybersecurity framework. You come with some subset, and then you try and use that across a whole industry like healthcare, and you're not getting at the right stuff to stop ransomware in the healthcare sector. So it's not, you're not looking at it from as broad of a risk perspective as you would if you were just using the NIST cybersecurity framework the way that it's supposed to be used. That said, I understand why a small organization might want to have something like the CPG, especially a board of a small organization, might want to have something like CPG so you have a checklist of stuff to do, right? That's helpful, but it's not going to solve the problem for that organization of, okay, we have a new threat that's out there. Are we actually addressing that threat? I think that the key is really, are we taking a risk-based approach here? How are we figuring out what our biggest threat is, and how are we addressing it? Regulations can help push people in that direction, but that's not a security program.
I can see you with your mic.
Sorry. No, this is a fascinating conversation for me. Again, in terms of our regulations, it is written from a risk-based approach perspective, and my CISO currently is going through an exercise of mapping our regulations line by line to the kind of federal level guidelines and guidance that these guys are talking about, right? The NIST framework 853 and the performance goals. And it's a really interesting exercise in making sure that our regulations align with what's coming out from the field in terms of guidance and best practice. So that'll be an interesting product when it's complete.
There's harmonization in action, which is the...
Because I think my next question would be like, given this, do we need another set of regulations, right? I mean, consultants have made billions of dollars mapping them all together, right? So what is the issue? I'm not part of the conversations like why can't we just say, hey, NIST, CSF, go for it? Like, what is the major pushback? Resources because of the size of businesses, or sort of what's the concern there?
Well, I mean, as a consultant that maps these things, I can't really complain. However, I would say, the issue, again, there's sort of a feeling after each bad thing that happens, we must react immediately and have something to do. And that creates more stuff out there, right? So, and the NIST cybersecurity framework was supposed to solve that problem. But cybersecurity is a big area. So if you're not, if you don't have unlimited resources to make sure that you're doing the best of every control set, then you have to do a risk analysis of that. And a lot of organizations are still not started at all, right? So then it comes down to, so the regs have to focus on the thing that's important for right now. And so then we end up back in the same conversation again about how do we get them to do this stuff that we know is bad right now? So that the Beau's point, we don't end up like 5 years from now, get to the point where they're putting the stuff in place that can protect from the thing that we know is bad today? How do we get it to be job number one today? And so just having a risk-based framework out there helps the people that have the knowledge and want to do the right thing, but it doesn't help for the organizations that have no starting point and don't know where to go, and really maybe don't have any incentive to do the right thing. So how do we get those people as well? So it's both trying to cover all at the same time, especially in a sector as broad as this it's a policy challenge. So.
Yeah, and I think if you look back in I think it was 2017, the HHS Cybersecurity Healthcare Task Force report was released, and on the front page of it, it's got like, here's 5 things that cause issues in the healthcare sector. 5 of the root causes for cybersecurity issues, and I think it was the number one thing was that the vast majority of healthcare providers lack a single full-time qualified security person on staff. So when we talk about who's going to do the risk assessment, who's going to implement these things, like a lot of these organizations they're resource starved. They're what the White House and CISA has called target-rich cyber poor. They just don't have the capability to do a lot of these things, and so we've got to find someone in the ecosystem who can help. I love the idea of shared services, shared CISOs. That's one of the things that came out of that 2017 report was an update to the law that allowed it to be possible for unrelated healthcare organizations to work together on things like cybersecurity, which was fantastic. We also need to, like I said, move upstream, move to some of the larger providers, not healthcare providers, but larger technology providers, so that when an HDO healthcare delivery organization gets their technology put in place, they don't have to go around and spend a bunch of money on top of what they've already spent for the technology to secure it. It's more securable out of the box. It sets things up to where you can do, security, where you can do forensic analysis if you need to, where you can be more agile in incident response, et cetera. So I think that there are a handful of things that we can look at that have some policy levers to pull, and that get us away from, whose regulation or whose cyber framework is best and which 20, 40, 80 points are the ones that you should put in place.
Awesome, thank you. So with that, thank you so much for that discussion. And we have a bit of time for Q&A. If anyone in the audience? Professor Healy.
That's really amazing, thanks. And I'm still working through in my own head, like where the regulations are to help the small thing, like a particular hospital in which are looking for the sector as a whole on the crash. So this gave me a lot. I'll try and just 2 quick ones. One, I liked what you brought up, Beau, there at the end of, hey, we passed this law that made these things possible, right? So are there changes that we need in the law that can remove the headwinds to help that are preventing good things from happening? And I'm really not concerned, but yesterday Governor Hochul said, hey, New York State is ahead on this and we're going to be doing what we need to do. Are we seeing more states that are following what New York State is doing on hospitals, and what can we do to try and keep all of that going in the right direction? Thank you.
So yeah, I don't have a sense of the landscape for other states, but I will say my door's open, my phone line's open. I would love to collaborate with any other states that are thinking about this to share experiences and the like.
Yeah, I also don't know that other states are doing the same thing, but they should. I think that I'll be really interested to see how your program comes out once you start getting feedback from the organizations that have implemented these things. Like, how does it work for them? Does it work for them? What roadblocks are they running into? So that other states can learn from what's worked and what hasn't. And so that everybody can build on that.
Yeah, this next year will be really interesting. So the regs were promulgated in the first week in October, I believe, and they have a year to comply with them. So I think we'll learn a lot over the next year as our varying levels of organizations wrestle with these regulations.
We might actually organize something with the other states.
Thanks. I love how you sort of set that up. They're like, hey, by the way, I think we're doing this too, which is great. Any other questions from the audience?
Hi, thanks for a nice, robust conversation. People love to point to HIPAA as a data privacy practice that intersects security and privacy. What would you advise people who are looking at that in terms of not a regulation so much, but a security and privacy practice, and say this is something where you should put these two together? I know we didn't talk about HIPAA here, but it's something that comes up a lot in terms of how people are designing what, not so much information security practices, but data privacy practices. Thanks.
I'd say, I mean,
Sorry, further context.
yeah.
AI.
Oh, AI. Well, I'd say that it was a pretty light touch security piece in particular originally, and the privacy parts, especially notice consent, were much heavier handed in the original reg. So, and now we're expecting the new move, we'll see what the new draft looks like, to be a little more specific in terms of what the security side will bring to it. And I think part of that is around concern, some of the concerns you see from new technologies, including AI, that they're moving in that direction. But it's also that the sort of change healthcare situation as well, like that there was this view, well, isn't healthcare regulated? And well, not really in that way. So was sort of the attitude about it, especially because it was a data issue in that case, and this is data that it's supposed to be covering. So I would say, because there have been a lot of compliance efforts and cases of where they've been brought against for security failures under HIPAA, but that's because people were doing absolutely nothing, right? Not because they were doing the thing. When I was in government, so this is still 10 years ago, people from the FTC used to say to me, it used to be, 10 years before that, so 20 years ago, we'd have these cases where people would be doing absolutely nothing, and now, 10 years ago, they're just investing in the wrong stuff or not investing enough. And those were the cases they were bringing 10 years ago for security. And I think healthcare is behind that, right? So the cases that we've seen in HIPAA are still the cases where people were doing absolutely nothing that were being brought, and now they're trying to raise it up to the cases where they've been investing in the wrong stuff. So healthcare, even though it's been regulated for a long time in the healthcare data area, it's behind in terms of just the general viewpoint of how much to be investing and what to be investing in, and are you really a focus on, are you investing in the right stuff, which is where some of this work comes in. But this is going beyond just the data piece of it, but the data piece in particular, there hadn't been as much focused on that. So as far as that ties to new technologies, we'll have to see if that actually works or not with the new regs, right? And whether the new administration will actually put the new regs into place. I don't think there's that much resistance to it, but we have to see what they are. So.
Any other questions from the audience? So I'm actually going to click on that a little bit as far as the data privacy. This is a little bit off topic, but as far as the sort of increase in third-party data aggregators, especially for health data, I know that this is sort of more of a security panel than necessarily a privacy panel, but Ari's already smiling, so go for it.
No. You mean in terms of the security of third-party data aggregators for healthcare?
Just like sort of the lack of controls around how the lack of privacy controls around how this data is being used and aggregated and handed around.
I mean, it's somewhat of a complicated issue because. And it's been talked about for a really long time. There's a lot written about it because, also tied up in that is health, health trials and just some of the academic work around healthcare and health. We learn a lot about healthcare through aggregating data on healthcare. So a lot of times the kind of same data that we use that we have complaints around for the sales, et cetera, and so there've been attempts to try and put controls on the use of the data versus the aggregation of the data, that probably makes a little more sense because you do want to get the benefits out of what we learn from blind studies, et cetera, part of the reason there's been a move to be able to kind of figure out how to anonymize data better, and use advanced math to anonymize more data, is directly for healthcare for this purpose, right? Can we still aggregate it together and solve some of these issues? It hasn't solved every issue in the space, and people still want to do healthcare studies and trials that you can map and figure out. At the same time, you don't want to aggregate that information. So, but it becomes very complicated. So it's not. I think a lot of times we hear of something bad that happens, and then people, there's a heavy reaction to it. But then in this particular space, there's a lot of benefit from keeping all the data and it's around, right? So, which makes it a lot more complicated. We've learned a lot and we've made some progress, but I think there's still more to do to stop. And, you were talking before about the overregulation and the innovation. I think that balance is a lot harder in the privacy space for healthcare than it is in some other spaces. But
I would tend to agree, just like the stakes are so high, but the opportunity is so great.
yeah.
So, Jay?
Okay.
And actually, yeah, Jay, and then in the back.
Oh, okay. I'll make it quick then. Sorry for what may be a basic question. Where I'm used to more regulation for the finance sector, the technology sector, where the U.S. isn't the only player because they're multinational companies. So I'm just curious, in what aspects of healthcare do we have to, are we focused on what Europe especially might be doing, or maybe to some degree Japan or other countries?
I know at least in medical devices, these are global markets for those devices. So in many cases, other countries just draft off of, well, if it's cleared by the FDA, it's good enough for us too. Not all countries do that. Some of them have their own standards. And in Europe, for instance, like CE mark has a specific medical device testing, security testing, and if you can clear that, you can be on the market in Europe. But I think that there is an opportunity there to raise the tide line for medical devices globally by having whoever pops their head up and has the best, strictest, most robust cybersecurity requirements for medical devices. Everybody else in the world is going to benefit from that. And even if it's not regulation, like the Mayo Clinic used to do this, they would push back on their medical device makers and force them into a higher set of capabilities because they recognized that they could do it for themselves and everyone else would benefit. So they were much more forceful than they necessarily needed to be just for the Mayo Clinic. So
I'd say I totally agree with that. Devices is the main one, but health apps as well, which sort of falls in the same thing, gets in that category. And the main reason for it actually is because in most of the rest of the world, health data is run by the government, right? The government systems, our health systems are government systems. I see our UK people here as examples sitting a few rows behind you, right? It's about government use of data and not about private sector use of data. So different situation. Yeah.
In the back.
What I find fascinating about the medical and the health sector is it's one of the most purely civilian infrastructures that we can think of. So I'm curious, as we think about the international landscape and the discussion about norms, criminal actors targeting different sectors, whether you sense any push from the healthcare sector or hospitals that say, but we should be protected. We have the Red Cross or the Red Crescents on us. We've always been better protected than a lot of others. Is there any, apart from the regulatory side of things, is there kind of a sense by the sector that more should happen at that level? Because a hospital is different from a bank. No offense to the financial sector representatives in the room, but whether there's any sense of that has transpired. We heard Anne talk about the UN Security Council session last week where the head of the WHO spoke, and I was just curious what you're picking up on that.
Yeah, I know that there have been some efforts, for instance, with the International Red Cross, where they were going to try and come up with a system to label hospitals as hospitals on the internet somehow. So the theory being that if attacking a hospital in wartime is a war crime, then how do you ensure that people who might attack them understand that it's a hospital and that you might suffer more consequences than if you're going after a bank, for instance. I also know that there have been a few private sessions where I've heard people say, like, if you go after hospitals as a cyber criminal or as a nation state, we're going to especially go after you with offensive capabilities or to the extent that you can with sanctions and other things. So I've heard a lot of conversation around that. I don't know that that's necessarily manifested in more restraint by adversaries. It used to be that a lot of them would, if they hit a hospital, they'd back off. They'd say, sorry, we didn't know this was a hospital, we'll unlock you, for ransomware actors. During COVID, I think that shifted, and now it's just all fair game to most of them.
Okay, excellent. Thank you so much. We're at time. I want to say thank you again to SIPA and Columbia for having us, and thank you to the panelists for being here. Excellent conversation. Thank you. And I think, Ari, you're going to make some comments.
I'm supposed to, as a sponsor of one of the sponsors, we're happy to help host the break that you're going to have. But I want to say thanks to Jay and the SIPA team. I think it's been a really great event, and honored to be a part of it and participate. Thanks.